Good afternoon, everyone. It is my pleasure to welcome you all to the Military and Veteran Education Series. This is a grant-funded series that provides knowledge of military-focused topics to all those in connection with service members. The series takes place virtually once a month on a Friday from noon to 1 p.m. Our training next month will be January 26th at noon, and we'll cover cognitive processing therapy for beginners. The first invitation for that will go out tonight at 5 p.m., so please be on the lookout for that. If you have any technology-related questions, please find our tech support Shannon in the chat. She will be happy to assist you. If you have any questions during the presentation, please type them into the Q&A tab in the taskbar, and we will get to them. My name is Zachary Ginsberg. I'm a second-year doctoral student in the Military and Veteran Psychology concentration, a VA HPSP scholarship recipient, and an assistant event coordinator for the Train Vets to Treat Vets program. I would like to quickly thank Dr. Angela Taveradick and Dr. Jenny De Olympia for putting on this continuing education series and for all their work supporting the veteran population. It is my pleasure to introduce our speakers for today's topic, Preventing Suicide in Veterans, Leveraging Data to Understand Veteran-Specific Risk Factors. Our first presenter is Rebecca Dreyfus. She is a licensed social worker and is the Suicide Prevention Program Manager at the Bedford VA. She has worked in suicide prevention for over 10 years, providing direct clinical services, including crisis support and risk assessment to veterans. She also does outreach and training to the community on risk assessment, lethal means safety, and safety planning. Other areas of interest include psychosocial rehabilitation and serious mental illness. Our other presenter is Dr. Andrew Peckham. He is a licensed clinical psychologist at the Bedford VA Medical Center and a research investigator for the VISN-1 Mental Illness Research, Education, and Clinical Center. As a member of the VA Bedford Suicide Prevention Team, he provides clinical care, consultation, and provider education about suicide risk. In addition, he serves as a co-director of the Interprofessional Fellowship Program in Psychosocial Rehabilitation and Recovery. Dr. Peckham conducts research on emotional regulation, impulsivity, and bipolar disorder, and has authored more than 50 publications on these topics. He's completed his doctoral training in the clinical science program at the University of California, Berkeley, his clinical internship at Harvard Medical School, McLean Hospital, and an NIMH-funded postdoctoral fellowship at McLean Hospital. Without further ado, I'd like to turn over to our two presenters. Thank you so much for being here with us today.
Wonderful. Thank you so much, Zach, for that really kind introduction. So in today's presentation, I'm going to get us started with the first part of our talk. And what we'll aim to do is to first talk to you overall about the scope of suicide among U.S. veterans, including talking really specifically about general risk factors that we know to be elevated for veterans who might be at risk for suicide. In the middle of the talk, I'm going to turn things over to Becky to talk more about risk assessment and lethal means safety. And then at the end of the talk today, I'll come back to discuss some recent data on specific suicide risk subgroups, really focusing on what do we know about emerging areas of concern for particular groups of veterans who might be at heightened risk of suicide now in this unique COVID and post-COVID era that we're in. And we will aim to leave time at the end to answer all your questions as well. And thanks again, Zach, for the really kind intro. So we hope that by participating in the training today, all of you will begin to be able to describe some differences in what we know to be true about suicide risk factors between veterans and civilians. We'll want to make sure that you have an understanding of how to assess risk and protective factors for suicide in veterans in particular. And we'll also be discussing the really specific importance of lethal means safety in veteran populations. I want to remind everyone that, as you know, by joining this talk today, we are going to be talking specifically about suicide. And this is a really intense topic that affects everyone in many different ways. So we just really want to encourage you at the outset to take care of yourselves, meaning that if you need to step away for a moment, to take a break, to go off camera, to step out, that's totally fine. And we want everyone to make sure they're taking care of themselves. We also want to make sure that you all know about resources that are available to you and to people in your life today. In particular, the 988 National Suicide and Crisis Lifeline, which, as many of you I'm sure know, is a 24-hour number that you can call any day of the year. By dialing 988, you reach a trained responder to talk to you about any specific crisis that is happening. If you're a veteran or a service member, you just want to press 1 after dialing 988, which would move you over to the Veterans Crisis Line. So we're going to jump right in today and talk a little bit about what do we know about the state of suicide among U.S. veterans. And much of what we know comes from the VA's own national report. So some of you will probably have seen this before, but every year, the VA's Central Office of Mental Health and Suicide Prevention commissions a national report looking at the scope of suicide in the United States. This is a report that covers suicide deaths across the entire nation, and it looks at many, many different correlates, clinical and demographic risk factors, and offers a top line view about how we are doing at suicide prevention over time, as well as who are the veterans who are most at risk for suicide. One really important caveat to think about with this report, though, is that it takes a long time to get these data compiled, which means that the data that we'll show you now is the most recent report from 2023, but the data goes through 2021. So the data I'll show you mostly has to do with about 2 years ago. So every time the report's issued, there's about a 2-year lag. It is publicly available, so happy to share our slides here, and you can access this yourself if you want to look at all the specific details. I think it's important to note a couple of things that are in the opening pages of this report. And I probably don't need to say much of this since we all lived through it, but 2021 was really not a normal year in so many different ways and so many different metrics, no matter how you look at it. So we know that there were nearly 500,000 COVID deaths in the US alone during 2021. This was really at the heart of the pandemic for many people. There were really significant disruptions to school, to our jobs, to our social networks, to our ability to travel. Layered on top of that, we know that 2021 was a really challenging year in terms of social conflict, racism, political violence, many things that were happening throughout our nation that caused people a lot of distress. We also know that, in particular, unfortunately, veterans were affected by many of these things in ways that were really profound, and in many cases were affected more than civilians. So several studies now have shown very conclusively that compared to non-veterans, veterans endorsed more significant increases in mental health concerns during the pandemic. So specifically, the pandemic was associated with things like higher rates of loneliness and stress and substance use disorder symptoms and mood disorder problems, particularly among veterans. So with all that in mind, we wanted to show you sort of the top line view of thinking about how have veteran suicide deaths changed over the past 20 years, and then what do we know about most recently in 2021. And what you see is that over time, particularly since about 2006, there was a really significant increase in the number of veteran suicide deaths in our country. And unfortunately, after seeing a decrease for 2 straight years, we saw that veteran suicide deaths increased in 2021. So clearly showing that we have a lot of work to do in preventing veteran suicide death going forward. And also really concerning, although potentially not surprising, given seeing the risk factors for what 2021 involved, that we did see this increase in suicide deaths during that year specifically. So I think it's most important, though, to be able to compare the suicide rate. So in addition to looking at the raw numbers, what this chart shows here is the age and sex adjusted rate of suicide, comparing veterans in that dark blue line to non-veteran adults in the lighter blue line. And what we see is that for years now, the gap between the veteran suicide rate and the civilian suicide rate has been increasing, such as there's been a higher suicide rate among veterans now for more than 20 years. Unfortunately, that gap widened significantly in 2021. So we saw that this rate, unfortunately, is worsening such that the rate for veterans is increasing faster than it is for civilians. We can also look specifically within our veteran population captured in this report to understand more about some clinical and demographic predictors of suicide death. And what we see, which is, again, really consistent with the civilian population, is that male veterans in that dark blue line there have a much higher suicide death rate than female veterans in the lighter blue line. This is true, again, in civilian populations and has been true for quite some time. What was really concerning, though, about the 2021 report that I do want to draw your attention to is that we saw a significantly steeper increase in the rate of suicide deaths, specifically among women veterans compared to male veterans in the latest data. And this was a really drastic difference between male and female veterans, suggesting that we really have some more work to do for making sure that we have strategies to specifically prevent suicide among female veterans. We can also look at differences in suicide as a function of age among veterans. So similar again to what we see in the civilian world, veterans, particularly in the age 18 to 34 age group, tend to have the highest suicide rate, and this has been true now for more than 10 years. One glimmer of hope that we did see in this most recent report, though, is that there was actually a notable decrease in the suicide rate for veterans who are over the age of 75. Now, this is actually really encouraging for a couple reasons, but among them, people over the age of 75 have for a long time had quite high suicide death rates. So this is quite encouraging to see that there's actually a decrease in the most recent report. We can also look at racial disparities in suicide rates, as you see here. And as you see, there's certainly significant differences in suicide rate as a function of race. But really the thing that jumps out in terms of most recent data about 2021 is there was really an alarming increase in the suicide death rate among American Indian or Alaska Native identified veterans in this particular year. And this was really a significant and more steep increase than we'd seen in any year going back that this report has been commissioned. So there's still a lot of research being done to try to understand exactly why this population showed such a significantly heightened suicide rate. But a couple of things, we know that people who identify as American Indian or Alaska Native tend to live in more rural parts of the country. And rurality has consistently been associated with higher suicide rates and fewer services available for suicide prevention in many parts of the country. We also know that many American Indian and Alaska Native communities were hit particularly hard by COVID. So as research continues, I think it'll be important to try to tease apart exactly why we're seeing the significant increase for that particular group. And then finally, I want to turn to a couple of data points the report highlights that now focusing a bit in more on veterans who are served by the VA recently. So everything I've shown you to this point has been across the entire nation. But now I want to think specifically a bit about veterans who have been served recently by the VA. And having data from veterans who are served by VA means that there's a little bit more nuance, there's more information we can use to understand even more specific subgroups and clinical risk factors. And one thing that we see really drastically is that homelessness remains a really significant predictor of suicide among veterans. And this is despite some really concerted efforts to reduce homelessness across the country. We still see that, unfortunately, many people struggle with homelessness, and certainly during COVID, the relationship between homelessness and suicide rates increased quite drastically. So just thinking about the people that you serve in your communities, the veterans that you serve, if you know someone to be homeless, certainly making sure that you're applying all the risk assessment strategies that Becky will talk about in a moment, and also thinking about ways to connect with potential housing resources to reduce that risk remains really, really important. The one thing that really comes across from the report, though, more than anything else, and this will be the last piece of data that I share, is that there's a very significant and profound difference between the suicide methods that are used between civilians and veterans. And that is that 72% of veteran suicides were by firearm in 2021. And this is compared to only about 52% of civilian suicides involving a firearm. So there's a really large gap in terms of the methods that are used, with veterans being significantly more likely year over year to use a firearm in suicide. This is actually increasing, as you see going around the circle, that veteran suicides from firearm have increased over time over the past 20 years. We know, of course, that firearm ownership is just much more prevalent among veterans, more than twice as likely. And we also know, unfortunately, that 1 in 3 veteran firearm owners will say that at least one of their firearms is stored unsafely, unlocked, and loaded. This is unfortunately similar to what we see in the civilian population as well. One thing I'll come back to a bit later in the report is that firearm suicide rates were also drastically higher among veteran women compared to civilian women, and this gap has really only widened considerably in the past couple of years. So we'll get back to talking a bit more about that in the last part of the talk. But among all the different clinical and demographic risk factors, we know that the single biggest one that differentiates veterans and non-veterans is the suicide method used, and specifically rates of firearm suicides among veterans. So I just want to finish this first part by pointing out too that the national report also has a section describing anchors of hope, things that should give us reasons to be hopeful about all the work that you all are doing, that we're doing together to prevent veteran suicide. So again, we saw this really encouraging and significant decrease in suicide rate, specifically for male veterans who were older, over the age of 75. Really the first time that we're seeing this in the data. We also saw that suicide rates actually declined for that high-risk 18 to 34-year-old male veteran group who were connected to the VA and were using VA care recently, which is really encouraging to see. And then finally, the VA also was able to look at changes in suicide rates for veterans who were experiencing gender dysphoria or any diagnosis related to challenges with gender identity. And suicide rates for those veterans have actually gone down significantly over the past 10 years, which is another really encouraging thing to see. So overall, we certainly still have work to do, but nice to recognize where progress is being made as well. And with that, I'm going to turn things over to my co-presenter, Becky Dreyfus, to talk about risk assessment and lethal means counseling.
Andrew. Okay, hopefully can make this as seamless as possible. Hey, Andrew, can you see this? Could you tell me?
I am not seeing that.
Okay. So much for making it seamless. Okay, there we go. I assume you can see it now.
Yeah, Becky, can you just go into presentation mode? There we go.
Yeah.
Perfect. Looks great.
Okay. Sorry for that. Okay, so thank you, Andrew, for sort of setting the stage for many of the risk factors and things to be for us as you know, either service providers or as veterans or as concerned citizens or, you know, community members of veterans. The next part, we're sort of going to be talking more in depth about suicide screening and suicide risk assessment. So this is sort of the approach that the VA takes to suicide screening and risk assessment. I'm sure for the clinicians in the audience, this will seem similar to the work that you're doing, even if it's not in settings that is, you know, veteran specific. And hopefully you'll find it, you know, sort of universally applicable. But I will try to mention some parts that I think are veteran specific. So these are the elements essentially of both, of really actually important elements, both of screening and assessment. So you're going to be wanting to ask about ideation, intent, plan, and access to means. So what is suicidal ideation? So these are thoughts, wishes, they could be like preoccupations, imagery, ruminations about death, dying, suicide. This is a time to be very specific and very direct. You know, whenever I do trainings, you know, I'm always encouraging folks to be very direct. This is not a time to say, are you thinking about hurting yourself? This is a time to say, are you thinking about suicide? Are you thinking about killing yourself? Because we need to be very clear and we want to know the answer, because that's how we can be most helpful to the people that we're serving. And again, other important questions: how to get detailed information, talk about the onset. You know, when did this first happen? Is this something that's been happening, you know, throughout the duration of your life? Is this something that just started? Does it coincide with a recent loss? Does it coincide with a change in medication? All of these, I think, are really important factors and could also affect next steps. So that's why all of these details play such an important role. Frequency, again, is another important piece of this. So how frequently, how intensely are you having these thoughts? And again, for some folks, it's going to be, you know, this is a lifetime of me having these thoughts. Other folks, this is a new onset. And then other folks, it's, you know, I've had it all my life, but it's worse now than it had been. And don't be afraid to ask lots of questions. Oh, I skipped over my last ones. About duration and severity. Okay, the next part is intent. This is one I really want to emphasize. Intent is one that I think people get really stumped on. And so this, in the CDC definition, it's that there is either implicit or explicitly the person wishes to die, has the means, and understands the consequences of their actions. So all three of those components. So this is different from, for example, the desire to die. You know, I think very often, and this trips up again a lot of our clinicians. If we ask our veterans, for example, like, how did you have intent? Did you, today, are you really wanting to die? They might say yes, because perhaps they really do have a desire to die, but that's not exactly what intent is. Intent is really all three of these components. And I think another way to think about this is that somebody may have a strong desire to die, but they may have a number of protective factors. For example, family, church, a dog, employment, things that are really keeping them from taking that step. So again, this is where sort of asking a lot of detailed questions really helps figure out and tease out what is the intent, the level of intent. And again, intent can also be derived, it can be derived both from your interview with that person, what they're saying to you, but also from what you are observing, or from what other information you're gathering from others. If they're working with other people in your program, if they are, if you know other people in their family, if you've talked to other people in their family, if there's reports, if you work, let's say you work with the police, if there's a police report. So for example, a veteran or a person might say, well, I took an overdose of 16 16 oxycodone, but I wasn't trying to kill myself. I was just trying to make the pain go away. But then, you talk to their daughter, and their daughter was saying, well, they were saying for the last 2 weeks that they really wanted to die. And that they were, they just wanted it all to end. So the intent is really based upon what you're hearing from sort of multiple places. So I hope that helps for folks. Okay, suicidal plan. Just checking how I'm doing on time. Okay. So a plan. So this is a clearly defined method that a person has selected to use to die by suicide. Again, you're going to want to ask details about the plan. So for example, one thing I tried to tease out with folks is, like, very often they might have, oh, I've thought about various methods. I've thought about, driving my car off the road. I've thought about jumping off a bridge. I've thought about all of these things. And people might define that as a plan. But that's not exactly what this is. A plan is sort of a detailed method. I have the means. I'm going to take my car. I'm planning on doing this in 2 weeks. So when you think about plan, that's really what it's getting at. And an important part about this is also the means, as I've mentioned. So whatever plan it is that they might be thinking about, or plans that they are thinking about, ask questions about the means. And I'm going to get into that in just a little bit. But is this something that they have access to? Do they have knives in their house? Do they, do they have a firearm? Do they have rope? Do they, how easily could they get that? Have they thought about it? Have they researched it? All very important questions to be asking. Have they engaged in any preparatory behavior to try to get those things? And all of this sort of will lead to the next step, which I'll get to, which is sort of coming up with a risk assessment. Okay. So now that you've sort of identified the thoughts, plan, intent, now the next step in sort of doing the risk assessment is trying to figure out what warning signs are there, what risk factors, and what protective factors. And all of this is sort of going to culminate in your assessment. So what are warning signs? Warning signs they can be emotions, they could be thoughts or behaviors that would indicate that that person might be at sort of high risk for suicide. And it could be that these are things that have been warning signs in the past. So for people who have had previous suicide attempts, maybe they have written they have written letters in the past to their family, or they've they've increased their drugs or alcohol use. So you could also phrase that to folks that way. But anyways, warning signs. So these could be preparations for suicide, drugs or alcohol use, anxiety, anger, certainly hopelessness, isolation, recklessness. There could be other warning signs. These are things that can, could come directly from the person. It could also come from the family member or friend. They might be seeing these things more so even than the person themselves. And actually, we're not going to go into this in this training, but these warning signs can be really helpful if you're doing a safety plan with a veteran. So very, very good, helpful information. A next important component of a risk assessment is risk factors. So when we're trying to determine somebody's risk, we're always trying to assess for the risk and protective factors. And we all have risk and protective factors. And some of these are modifiable and some of these are non-modifiable. So what do I mean by modifiable? These are things that we can change, such as Andrew was saying before, maybe someone's homeless status. Homelessness has a big effect on somebody's risk for suicide. So if we can change their housing status, that can go a long way towards reducing their risk for suicide. Other modifiable risk factors could be their access to healthcare or mental health care. So for example, maybe they don't have health insurance, and we could change that by helping them to apply for Mass Health, or helping them to get an appointment with a therapist. So anyways, those would be the modifiable ones there. And then there are, of course, non-modifiable risk factors. So those would be things like a history of suicide attempts, a history of mental health issues, a history of trauma, certainly being a veteran, unfortunately, is a risk factor. Being a certain minority groups, those can be a risk factor. That is not modifiable. So anyways, this is a pretty comprehensive list of risk factors, and these are all things that you would want to be assessing for. Access to lethal means, history of mental health hospitalizations, mental health history, losses, medical issues. Moving on, this is the list of protective factors. So again, the goal in all of this is really to try to increase the protective factors and reasons for living. So this would be, as I've already mentioned, increasing access to healthcare, mental health care, a connection to family, connection to friends, church, any kind of social connectedness is an important, I think actually Andrew gets into that a little bit later. Those are all important things. All right. So this is, I'm not going to go into this, but these are the two tools that the VA uses. The top one, the Columbia Suicide Severity Rating Scale, is our screening tool, and the Comprehensive Suicide Risk Evaluation is our is the tool we use for risk assessment. So what do we do with all of this information? So we actually congregate this to come up with a determination on acute and chronic risk. And then within those categories, we come up with either a high, intermediate, or low determination. So in terms of high acute risk, these are usually folks that have suicidal thoughts with intent to die and the inability to maintain their safety. These are usually the folks that are going to need an inpatient hospitalization. So there, actually, I'll show you in a little bit, but there's a nice graphic that actually any of you can should be able to access. It's through the MyRec. There's a link in the slides. But it sort of breaks all of this down. So it's sort of like, based on your risk assessment, sort of what is the treatment level that that person needs.
Becky, this is Angela. I just wanted to ask a question that an attendee had.
Oh, yeah.
If maybe you could clarify between a suicide attempt and a suicide gesture.
Yeah, so again, not something we'll get to go into today, but generally we're moving towards sort of standardizing language. So generally speaking, we would classify things as as self-directed violence. So either suicidal self-directed violence or non-suicidal self-directed violence. So if we felt, for example, that something was non-suicidal in nature, so if somebody was cutting, for example, and we felt like there was no suicidal intent, the language that we would be using would be non-suicidal self-directed violence. So I'm going to make an assumption here, but by suicidal gesture, I'm guessing that the thought would be that perhaps the person had a suicide attempt and maybe had some ambivalence there. That would be my guess. So in terms of like language classification, perhaps it would be maybe a undetermined self-directed violence. That is sort of a subcategory of that. So if it was undetermined, if it was suicidal in nature. So anyways, that would be that. Yeah, is that helpful? Is that did I answer that in the way that that you were looking for?
I don't know. They haven't gotten back in terms of feedback, but I think you're really highlighting kind of the power of language and maybe like taking out potential judgment that people could use when they say gesture versus other things.
Yeah, yeah. I mean, it is absolutely true that very often people have either have ambivalence or you know, there's so much complexity to you know, either attempting suicide or towards taking that step. You know, substances also come into play, so it can be so hard to know you know, the level of intent. Yeah. So that's where I think the language, I guess that's why I was focusing on the language there. Yeah. I am worried about the time, so I'm going to move ahead. Maybe actually I won't spend so much time, but anyways, these are the sort of the risk assessment area. So intermediate acute risk. These would be maybe somebody with thoughts of suicide, but the ability to maintain safety. So this might still be somebody who needed a hospitalization, but it also could be somebody who didn't need a hospitalization. Maybe they just needed an intensification of services. So for example, maybe they needed an IOP, or perhaps they weren't connected to services at all, and they needed, you know, connection to therapy or med management. So it sort of depends on the person. Certainly a safety plan would be recommended in this case. And then there would be low acute risk. So if you'll notice, there's no category for no risk. There's only low risk, because of course none of us are at no risk. So I sort of appreciate that. Okay. And then there's the chronic side. So all of us, I should say, when we're categorizing folks both in terms of their acuity and in terms of their chronicity, because all of us will have both components. Okay, I think I'm gonna plow ahead because I'm worried I'm taking up too much time. But if you are curious and checking out more about this is actually what the MyRec sheet looks like. It's pretty cool. I actually have it posted up in my office because it's so handy. Okay, so I'm going to go into lethal means safety right now. So as Andrew mentioned, lethal means safety is so important. You know, veterans are overwhelmingly using firearms as a means of suicide. So keeping them safe, talking about lethal means safety is such an important part of keeping them safe. So what is lethal means safety? So it's about building in time and space between that person having the thoughts about suicide and then taking that step. So it's meant to be a collaborative and you know, person centric approach to, you know, to really support that person in taking the steps to help themselves, to keep them safe. And it's meant to keep to prioritize really that person's values and priorities. So what we know is that someone is often thinking about suicide for under an hour between when they're having the thought and when they take the step. And in the case of firearms are fatal in about 90% of cases. Firearm injuries are fatal in about 90% of cases. So this is why there's such a focus on firearm safety when we're talking about lethal means. So ideally, you know, we want to reduce access to the lethal means. And research shows that if we can reduce that person's access, that 90% of people will go on to survive. They will not go go on to finding a different method. So for example, if we are able to reduce their access, let's say to, you know, a bridge, if we're able to talk to them about reducing their access to that specific bridge, then they're not going to go on to find a different method. So in terms of firearm or gun ownership, you know, firearms are very important to veterans. So it's important to go about this in a respectful manner, in a way that, you know, shows value and importance to their, you know, to their preferences. Ask them about it, ask them lots of questions, including, you know, what are their practices around safe storage? Do they use a gun lock? Do they use some kind of other mechanism to keep their firearms safe? And familiarize yourself. Take the time to, you know, show them that it's important to you, by familiarizing yourself with it. And I will tell you from the times that I've had these conversations with my veterans that they are not shy about telling me about, you know, their safe storage practices. They loved it. It's conversations that go on a long time. So don't hesitate to have these conversations. These are some really cool resources like Cover Me Veterans. This is like something that can go on the firearm of a personally relevant image, again, as a means of trying to prevent a veteran from suicide. These are some other cool resources on lethal means safety. So I'm gonna skip ahead because I ended up taking a long time on the other parts. Okay, so I'm gonna stop sharing and I'm gonna hand it back over to Andrew. Okay.
Awesome. Thanks so much, Becky. So I'm going to go back in and finish up the rest of today's presentation. Can everybody see this okay? So far, so good? Great. So moving on, we're going to talk finally about a couple really recent developments just within, I would say, the past year to 18 months from the research literature to help us understand who is maybe more at risk than other veterans, among veterans specifically. So Becky talked really nicely about some of our overall understanding about how to assess risk and thinking more specifically about how lethal means counseling fits into our risk assessment. And I want to just highlight a couple ways that the research literature is helping to point us towards specific populations, specific interventions that might be really important in the current context of where we are now in 2023. I do want to point out that, of course, like this is not an exhaustive list. And if you have ever tried to do this search on your own, there are hundreds, maybe thousands of different studies that have been done to try to understand the various clinical and demographic factors that point to increased suicide risk among veterans. So what I'll show you next is certainly not exhaustive. It's a selection of some recent studies that really highlight ways that risk factors might be emerging or important to consider right now. Firearm usage really does, again, tend to be the biggest distinguishing factor. So again, we can go into all of these different clinical and demographic variables, which for some veterans and for some cases in treatment planning might be really helpful to know. But if you're thinking about like overall top line factors to take away, thinking about differences in firearm usage and then also thinking about ways to practice lethal means counseling is probably the most effective single intervention you could think about using. But that being said, I want to talk a little bit more specifically about some recent data on women veterans and firearms. I want to speak a bit more about some really recent work looking at how COVID affected suicide risk factors for veterans going through those years. And then finally finish by talking a little bit about some of the unique relationships between gambling and suicide risk. So first, talking about lethal means safety and women veterans. As we said at the outset, looking at some of the data from the most recent national report, it's very clear that the firearm suicide rate among female veterans is just really drastically higher and getting larger compared to women who are not veterans. So this paper that was published recently by Talia Spark and colleagues really tried to start understanding what are some of the things that we need to start considering about how to tailor lethal means counseling specifically for female veterans? And what are some particular things that clinicians could do now to start working on this problem of this really drastically high and rising rate of veteran suicide death among women who use firearms? So one of the things that they took away from this paper is that it's really important when you're asking about firearms to not just ask about, does someone own a firearm, but do you have access to a firearm? And that might seem like we're splitting hairs here, but this is important to think about in the context that men tend to be much more likely to own firearms than women on average, and including in the veteran population. So by making sure that you're asking not only for someone sitting in front of you, do you personally own a firearm, but also, is there a firearm in your house? Is there a firearm that you have access to in your life? Then this is important because we know, unfortunately, that many women veterans who take their life are using a firearm that is not their own. So really important to assess, do you have access to a firearm? It's also important to ask specifically about handgun access. So I know now we're getting into more specific details, but looking again within veterans, male veterans are more likely to own more firearms than female veterans, just like we see in the civilian world. But female veterans are actually slightly more likely to own firearms, handguns specifically, compared to male veterans. And this is concerning because handguns are much more likely to be used in suicide deaths. So asking in particular about, do you have access to any firearms and do you have access to a handgun is a really important recommendation they make for working with female veterans. And then practicing all of the lethal means strategies that Becky recommended just a moment ago. The last recommendation I'll highlight for this study is that the authors recommend taking a motivational interviewing approach to think about how a veteran's beliefs about personal safety fit into any of their storage practices and any of the ways that they think about storing their firearm in their home. So unfortunately, many female veterans report owning firearms because of past experiences with military sexual trauma or assault or interpersonal violence. And many female veterans report in the literature having to have a firearm for personal safety and really believing that the firearm is an important part of being safe. So motivational interviewing is really about opening up a conversation for how do we make you most safe by making sure that you are storing that firearm in a way that is going to not only prevent other people from inadvertently getting access to it, but also to build in that time and space for yourself. Like Becky mentioned, if you do find yourself to be in a suicidal crisis. So taking a safety approach very broadly and thinking about how firearms fit in. The paper has a number of other recommendations for research as well, if you're curious and diving into that a bit more. The second research finding I want to highlight is thinking about how COVID affected the suicide risk for different veteran subgroups. So we know overall, thinking a little bit about how suicide rates rose in 2021, we looked a little bit at the clinical and demographic factors that may have been part of that. But what was really notable about this paper that was published in JAMA Psychiatry recently is that they were able to take a longitudinal sample where they looked at a large nationally representative group of veterans who were assessed actually before the pandemic. So they filled out a survey in the fall of 2019 before things really changed, reporting on their lifetime experiences with suicidal thoughts and behaviors, also reporting on mental health symptoms and loneliness and employment and things like that. The nice thing about this study is that the same group of veterans was able to be reassessed then during COVID and then in the summer of 2022, just about a year ago. So they were actually able to look at predictors of new onset suicidal ideation, veterans who had not thought about suicide before, who started considering suicide during COVID, as well as predictors of suicide planning. So trying to understand what are the things that are associated with somebody who has never made a suicide plan in their life, now making a suicide plan in the context of COVID. Not an easy study to do. Couple of the things that popped out is first looking at what are the biggest predictors of new onset suicidal ideation. One of the largest things that jumped out from the data is that veterans who reported lower purpose in life before COVID were significantly at higher risk for thinking about suicide for the first time when COVID hit. The second biggest factor was having more loneliness before COVID happened. So before anything changed in 2020, veterans who reported feeling more lonely were much more likely to have suicidal ideation for the first time in their life during these years of COVID. There are also a couple of other risk factors that jumped out, things that you would probably expect, like worsening of relationships during COVID, more problems with alcohol use disorder or drug use before COVID. All of these things were certainly associated with suicidal ideation as well. But the big two were lower purpose in life and more loneliness. Looking at new onset suicide planning. So again, what are the things that predict someone who's never made a suicide plan before doing that during COVID? The biggest one, probably not surprisingly, was having greater pre-COVID psychological distress. Just really sort of a catch-all for people who had levels of depression and anxiety and other problems that were not suicide that predicted more suicide planning during COVID. But also, we see the second biggest predictor again was a lower purpose in life before COVID. So we see really in both of these findings, having purpose and mission and sense of being driven in life is really important. So across all these studies, we see less purpose and loneliness are really the big two that predict suicidal ideation and planning, predicted the onset of these things in veterans. And I'd really encourage you all to think about, like, beyond the clinical interventions that you may know how to do really well, what are some bigger picture interventions that you might be able to offer to the people that you see that could increase either their purpose in life, their sense of mission, or to decrease loneliness? And I can just say briefly within VA, some things we're excited about are making sure that we're really offering social opportunities, veterans coffee hours, places to socialize, places to be that don't require a lot of money that we can recommend that people build into their lives in addition to treatment plans, as well as making sure that people are connected to volunteering and jobs and education and things that might help to boost up that sense of purpose. Finally, I want to end today by talking a bit about gambling and suicide risk. And this may not be the first thing you think about when you think about suicide, but I just want to point out a couple of specific things to note. Veterans have much higher rates of gambling and problem gambling in particular compared to non-veterans. So there's a baseline risk for gambling problems. Massachusetts is a relatively interesting place to be thinking about how to treat gambling disorder, in that the state of Massachusetts has the highest per capita rate of lottery ticket purchasing in the whole US. There's also been a large increase in availability of gambling in the past couple of years. First with state legislation legalizing casinos over the past 10 years, really increasing access to casino gambling in a couple parts of the state. And then on top of that, the widespread increase in sports betting just in the past year. And the biggest red flag that I think about here is that there's a significant and well-known association between problem gambling and suicidal ideation behavior. This has been known in veterans for quite some time. So this is looking at a study way back 20 years ago, looking at relatively severe group, veterans who are seeking treatment for problem gambling. And what they found is that lifetime suicide attempts were very high in the sample. Nearly 40% of veterans who are presenting for a gambling disorder treatment said that they had a lifetime suicide attempt. And of those veterans with a suicide attempt, nearly 2/3 of them described their most recent attempt as being related to gambling. So certainly there is a perceived connection here that's important to think about. And then finally, taking a look more recently. So looking just at this past year, another nationally representative sample looking at veterans who didn't gamble, veterans who gamble but don't really have a problem with gambling, and veterans who endorse symptoms of problem gambling, showed that first, veteran gambling remains extremely common. Large number of veterans engage in gambling. Nearly 5% actually meet criteria for at-risk or problem gambling, which doesn't necessarily seem like a lot, but that means 1 in 20 veterans, at least by this definition, would potentially meet criteria for more significant problems with gambling. And again, we see the significant association between suicidal thoughts and gambling coming up in the sample. So certainly something to think about as you're assessing someone and learning about who they are and what they do. As someone mentions gambling, being able to assess first, does this interfere with their life? Do they have symptoms of gambling disorder? But then also thinking about potential relationships with suicide and building that into your safety plan. Plenty of references we can offer. We're happy to share the slides so that you can look at this yourself. And I know we want to pause here so we can get to your questions. And thanks everyone for joining us today.
Thanks so much, Andrew. Really appreciate it. So in terms of questions, somebody asked about the intersection of MST and the, sorry, I'm just scrolling through this, intersection of MST and prevention of sexual violence among active duty service members, what kind of trends, are are current in today's research?
Yeah, so I'm not familiar myself with like the specific most up-to-date information on preventing MST. I can tell you that you know, from the suicide prevention perspective, certainly experiencing MST is a large risk factor for suicidal ideation and behavior. It is something that our team will absolutely assess and make sure that we are addressing within treatment. So I would certainly encourage that everyone absolutely assess for the presence of military sexual trauma and think about that as a specific suicide risk factor. But in terms of the data on what the question was about active duty, I'm not as familiar with that. Becky, I'm not sure if you have anything to add.
Yeah, unfortunately I don't know. I know I think most branches of the military have sexual violence officers and training programs, but I don't know exactly what that entails. And I think there was also it sounded like you had perhaps a male veteran MST survivor. I believe Bedford has an active Andrew and I work at the Bedford VA. We have an active male MST group, I believe. So
Yeah.
I don't know if your veteran is eligible for VA services, if they go to Bedford, that might be an option for that person.
I think the follow-up question is, what do we know about how many female vets are MST survivors?
I don't know the numbers off the top of my head.
I don't either. It's, you know, unfortunately very common, and it's something that we really want to make sure that we are continuing to assess for everyone.
The next question is, are women vets more likely to die from homicide by lethal weapon than non-veteran women? I think I can answer this and say yes. We know that that is true. I don't know the percentages, and I don't know the additional research, but I don't know if Becky or Andrew, you want to add anything to that?
No, I agree with you, Angela. I don't have anything to add there, but definitely, like you said, is still higher rates for sure.
Let's see if there's anything else. Are prospective members of the military screened for suicidal ideation? In other words, are vets already prone to this problem?
Certainly veterans are, I mean, I'm sorry, certainly prospective military members are screened for mental health, and certainly they're screened for risk to suicide. I think this is actually a big issue, especially for folks currently serving, that it goes not reported because folks, I think, are primed to know that either that could be a rule out, frankly, for or at least there's concern that it's a rule out for getting in or for getting discharged prematurely.
I can add to this and say I'm aware of research on ACEs that shows that the veteran military population has a higher incidence of ACEs, which is, you know, childhood traumatic events than the regular population. So that data point is there. I think that's it. Thanks. I need more coffee. So ACEs is adverse childhood experiences. Thank you. I think that's it in terms of questions. So we just wanted to thank you for your presentation today. Very informative, very detailed. I like how we're like digging further into the assessment process. It's really helpful to get those recommendations that you guys have. And we hope to see most of you, all of you, at our next presentation after the holiday. So everybody take care.
Thanks, everyone.
Thanks so much.